Thank you, Sonal, for the kind invitation. And I'm going to talk about a few situations intraoperative. And she mentioned to me that based on the diabetic retinopathy-based situations in surgically, while we might face some challenging issue during the surgery and how we try to work around it. So what I'm going to show you is two cases of tractional detachment, not absolutely typical diabetic retinopathy, but they could be with any kind of a vascular situation and a situation which comes in during that process. So this is a young girl actually, most likely probably had a vasculitis based residual sequelae, which you see as a tractional component which is spilling over to the macular area and reducing her vision. So you can see that just as the arcade on the superior side progresses, there's a stiff traction. So the aim of the surgery was to reduce the traction and resolve it on the macular area. And what I had aimed originally was that I'll just make this kind of a radial, this linear retinectomy to relax this stiff fibrous tissue, because this is a thick intraretinal contraction and there's no membrane there which can be removed to resolve the traction. So the aim was just to make sure. And since it's a vascular component, I would expect a lot of bleeding sometimes to happen because of the intraretinal component being involved. So we undertook this case to do a retinectomy, and as you see, I just make a good diathermy mark so that I don't encounter a lot of bleeding, and making a linear cut to relax that area. And I had presumed that by doing so I would be able to do adequate relaxation to make sure that the macula gets flat in the process. So as you see that I'm increasing the retinectomy size and then putting in perfluorocarbon to assess how that traction resolves. And slowly you see that there is some traction which has decreased, but there are still folds which go around the macula which would obviously compromise with the visual function. So at this stage I've filled up with PFCL just to make sure that there's no spillover bleeding which goes to the central area, and I've got better control. It's like a third hand which gives weight to that particular area. And then undertake a radial retinectomy here, because I feel maybe by relaxing a little bit of this radial component I may be able to further relax those folds which are radiating just over the macular area. Actually, with the constellation one, there's a proportional control, linear. So I mean, you could have a preset of maybe 100% also, but as you are tapping the foot switch, you are getting an increase 5, 10, 15, 20, 30. So the minute you feel that you've got an adequate reaction, you could stop. Or you could, if you like to have a preset of 20, 30, 40, then you could just keep it there and press it fully also. So I usually keep it on the linear thing where, because in some cases it comes in, I require a very light one, and at some where I'm totally occluding a bleeding vessel, then I want a more whitish burn. Or like if I'm preparing for retinectomy on a large vessel, I would like a whitish burn. So there I tend to do a little more. So it's on a linear control that I would use. So anyways, that same linear incision I'm further relaxed, and then I go in with a high mac to see, because of this chronic traction there's always some membrane or an ILM based traction which is also playing some role. So you can see that there's a definite thickened membrane or an ILM tissue which is distinctly there and is coming off. So all these components would help relax the central area. Because of this chronic traction, there's some component which is very stiff and the radiating folds have relaxed to some extent. And now you see that there is a mild traction here which is still there, which has come up and is allowing a few PFCL bubbles to migrate inside. So that means that traction is not totally gone. Otherwise, usually that would not happen if you've relaxed it further. So the essence of showing this case was that I planned to do a certain amount of retinectomy, but I ended up increasing it to a large extent. Although the aim of the surgery is not to have anything spill over to the macular area, whether your bleeding is there or make sure that the retina goes flat at the end. And this is the final post-op picture. So you can see that the macula finally got well settled in the central area with a reasonably good visual improvement to some extent. But you see the extent of posterior retinectomy which it went up to, all the scarring. But end of the day, the central area is well preserved, although the retinectomy went much more than what I had planned to begin with during the surgery at that stage. So So any questions at this stage, or how any of you would manage it in a different manner? So we are first removing some of the hemorrhage, residual hemorrhage, but it's a stiff TRRD on the temporal side. As you'll see, there's a detachment, and the temporal part is got extensive fibrosis. So posterior pole, I'm just putting some perfluorocarbon to assess as to how far the PFCL allows me to flatten, and this part is totally fibrosed. So I anticipate that, and I kind of I first try with air fluid exchange as to how it's behaving, but I realize it's very stiff and is not going to flatten. And now you see that I made a retinectomy, but it definitely seems to be going out of hand in that sense, because the traction is spanning through and through from superior to inferior, and slowly I make radial nicks to kind of reduce the amount which is going posteriorly. But you can see that the posterior part of the lip of the retinectomy instantly starts to retract and going more and more posterior, and this is something we face sometimes with even PVR cases. This is of a PDR based pathology which has gone on to that. So here I think at this stage we had chosen to put the buckle because of this anticipation, and I tightened it further to reduce the amount of retinectomy which may be required. So this is a situation where a buckle would help you reduce the amount of traction inside, because there's only so much you can cut if it's going very posterior, and you can see that it's come so close to the macula, the posterior lip of the retinectomy. But now you can see that with the buckle there's adequate support on the peripheral side, which allows you to get some extra leeway as far as giving a tamponade externally and reducing the need for retinectomy is concerned. But these are both situations where on table things got out of hand in terms of anticipating the retinectomy and what you would do in those circumstances.
Any other case that you have?
No, these two.
This much.
Yeah.
Anybody from the audience who would? Yes.
I'd like to know when you do radial retinectomy.
In such situations where you know that the extension of the retinectomy is no more going to help you by just going linearly along the circumference, and the more you keep cutting, the more the posterior part of the retina keeps going towards the macula. So there, more linear is not going to help you beyond. So then you make radial nicks to relax and get a little relaxation in the central part, so that the extension of the posterior lip doesn't go. So those are required in more rarer circumstances, because most of the times you will get away with the circumferential kind of a retinectomy. But where there is extremely stiff traction spanning the whole area, then your circumferential alone doesn't work at times. So